emergency nursing, diabetes education, primary care, pediatrics, lactation, and public health. Jacqui's worked with the local public health authority for 8 years and has been with the Oregon Health Authority's newborn screening program for the past 3. Vivian Sue is a research analyst with the Family and Child Health section of the state's Public Health Division at the Oregon Health Authority. She has over 10 years of public health experience supporting both the Early Hearing Detection and Intervention Program, as well as the Birth Anomalies Surveillance System Program. Her responsibilities include identifying needs patterns, conducting surveillance activities, improving data quality, analyzing and communicating key observations to the public to strengthen these public health programs. So we're very fortunate to have both of them join us today, and we will get started with Jacqui.
Thank you, Ellen, and thank you, WIC nutritionists. It's really nice to be here today. I do have some special ties to the WIC program. When I worked at the local public health authority, I worked kind of alongside WIC when I was doing the home visiting programs, and then I had the opportunity to supervise the WIC program for a year and a half. So WIC is dear to my heart, and I know how important the work is that you do. So just thank you for that. So we're just going to talk about newborn blood spot screening today. My role with the state lab is really to promote newborn blood spot screening. So I do a lot of training and education for birth facilities, community birth providers, and clinics who collect the specimens and make sure they're meeting our state metrics. And it's a really rewarding role. So my passion, as you may have noticed, is kind of revolves around families, especially young families. And this is a good way to do that without working shift work and still being able to have that positive impact. So we will move to the next slide. So there's 3 screenings offered to all newborns born in Oregon. So the critical congenital heart disease screening, the hearing screening, and newborn blood spot screening. And newborn blood spot screening is what I am going to focus on. Next slide, please. So what is newborn blood spot screening? So this is our state public health program. And what we want to do is identify infants with treatable medical disorders which otherwise may go unrecognized, and our goal is to avoid or prevent adverse outcomes. So our goal is really to identify and start treatment for affected babies within the first 2 weeks of life. So the screening helps to prevent death, permanent disability. Most babies look and act healthy at birth when they have one of these disorders. So it's really not until you do universal screening that you identify them. The disorders that we screen for do have treatments. Now, treatment doesn't always mean cure, but there is some management that we could do to promote this baby to have a positive, healthy life as best we can. Next slide, please. So there's about 4 million babies born in the US each year, and over 97% of these babies receive newborn blood spot screening. So out of those 4 million babies, newborn blood spot screening saves or improves the lives of over 12,000 babies each year. If we drill down to the state level in Oregon, we screen about 40,000 babies each year, and around 100 of them end up being diagnosed and treated for one of the conditions on the panel. Next slide, please. So when we look at incidence, newborn blood spot screening, really we're going to confirm a disorder on about 1 in 500 newborns in Oregon. We screen for 46 different disorders, and out of that, almost 20 of them can kill or severely harm a baby if untreated within that first 2 weeks of life. We're a 2-screen state, so that second screen helps to detect later onset conditions. So it's possible that the first screen is within normal limits, and it's not until the second screen that something flags as positive. Next slide, please. So when we look at who are our partners in this, so we have the Oregon State Public Health Lab in the middle. That's the OSPHL. So within that, we have our newborn blood spot screening laboratory, we have our data entry team, and we have our follow-up team. So that kind of comprises the majority of our program. But then we also have our partners. So we have our OHSU medical consultants. So if a baby screens positive, we will outreach to OHSU, to the specific department, depending on the disorder, to loop them in and basically say, hey, this baby screened positive. You know, they're doing the confirmatory testing. And then we also loop in the primary care provider for the baby. And we do this care coordination to ensure that everybody's on the same page for what happens next. It's up to the primary care provider to outreach to the family to say, hey, your baby screened positive. Here's what we're doing next. So our lab is a screening lab only. So any confirmatory testing will need to be done by an outside lab. On the left of the slide, you see submitters. So we don't just do newborn blood spot screening for Oregon. We also do screening for New Mexico, Saipan, Guam, some military bases in Japan, and some Navajo nations as well. And then kind of overarching, we have an advisory board that helps kind of direct how we want the program to work. The advisory board will review new conditions and determine whether a recommendation will be made to add the new condition to the Oregon Newborn Blood Spot Screening Panel. Next slide, please. And I also wanted to mention that we also rely on our community partners such as WIC and the Family and Child Health Home Visiting Programs, really just to support education and information about newborn blood spot screening and really just to direct families, you know, where to go, what are reliable resources for getting more information about newborn blood spot screening. So when we look at the history of the program, so our program was actually one of the first in the United States. We started back in 1963, and we started screening for PKU. And then from there, we continued to add new disorders to our panel. The most recent disorder we added in 2025 was infantile Krabbe disease. And if you look at the next slide, you can see here are the 46 disorders that we screen for on our panel. There's a national panel of disorders. When a new disorder is added to the national panel, our advisory board will meet to determine if they will add it to the Oregon panel. And because we're screening for 46 different disorders, we want to be very careful when we're talking to families about screening and what we're calling it. Back in the day, we called it the PKU test or the PKU screen, which makes sense, right? Because that's where we started with screening for PKU back in 1963. However, we're screening for 46 different disorders today, so we want to be careful that we're not still using the PKU test or the PKU screening when we're working with families. We don't want to imply that we're only screening for one disorder. And if their family has only heard this screening called the PKU, if their baby screens positive, they're going to think their baby has PKU. So we want to be careful with the information we're giving families, that it's accurate and it's transparent. So newborn blood spot screening is a bit of a mouthful, but it's a more accurate term for describing the screening. Next slide, please. So there's different parts to our program. I focus more on the pre-analytic side of things. So prenatal education, specimen collection, transport. That's really my role, is to help facilitate that within the facility or the clinic. Then we have our analytics, which is really the screening itself. And then post-analytic is our short-term follow-up and long-term follow-up. Next slide, please. So this just gives you a visual snapshot of the collection process. So that first specimen we want collected as soon as possible after 24 hours of life and before 48 hours. And then it gets sent to the state lab. Our goal is to receive specimens within 48 hours from collection time. And then we run our screening. Takes us a minimum of about 48 hours to turn around results from when we've received the specimen. We're doing a lot of different screening, and some of those incubation periods are long. So for a first specimen, we would expect to report out results no later than 7 days of life. If it was one of our time critical disorders, we really want to have that called out to the primary care provider no later than 5 days of life. And this is what gives us the best outcomes for the babies. And then we basically do the same thing again. So the second specimen we like collected between day 10 and day 14 of baby's life, and then again sent to the state lab quickly. We run the screening. So for a second specimen, which is typically collected at the primary care provider's office, we want those results available typically between day 14 and day 18, just depending on when the specimen was collected. Next slide, please. So the specimen itself is collected on special filter paper. This is a picture of our newborn blood spot screening specimen collection card. There's definitely some tips and tricks to collection. I spent a lot of time teaching our submitters how to collect the specimen using best practice techniques, which is a little bit trickier than it might seem. Next slide, please. We are going to discuss a case study briefly, and this is a true case study. This is baby Maisie, the picture on the slide, and she was born in Oregon 2 summers ago. So this was the parents' third child after 2 healthy kids and 3 typical pregnancies. So the parents were aware of and thankful for newborn blood spot screening, but really didn't have any concerns. Maisie's mom said, you know, the things that the test screened for are rare and not likely anything I ever have to worry about. And Maisie's first newborn blood spot screening specimen was positive for MCAD. And MCAD, as you are probably well aware, is a fatty acid disorder where the body does not break down certain types of fatty acids, so they can't be used for energy. So these babies cannot go long periods of time without feeding. And as we all know, newborns are predictably unpredictable when it comes to feeding. So this is a really big deal, and this is one of our time critical disorders. Next slide, please. So in Maisie's case, screening results were available when she was 5 days old. And again, for a time critical disorder like MCAD, it meets our goal of a call out by no later than 5 days of life. So what we do at that point is care coordination. So reaching out to the primary care provider to let them know what next steps are. The primary care provider reaches out to the family, and then of course we reach out to OHSU and kind of loop everybody in. So Maisie had her confirmatory testing, and really because of newborn blood spot screening, Maisie is able to grow and thrive. So the picture on the left, she was a flower girl in a family wedding, and then the picture on the right, this is her just from a few months ago. and her parents say she is just a ham. But because everything went well, this is a really good example of how newborn blood spot screening process should work so that we have the best possible outcome. And those state metrics around collection timing, missing information on the card, how to collect an acceptable specimen, and transit of specimens, we use all that data and we use all of our metrics so that babies like Maisie have the outcome that they deserve. So this is a really positive case study, which is great. But if we hadn't met one of those metrics, if that specimen wasn't collected on time, if it didn't make it to the lab in a timely manner, if there was any type of delay, then this could be a totally different story. Right? One of the first symptoms of MCAD is a baby who doesn't wake up from a nap. It is just one of those disorders that comes on so quickly. Those babies tank so fast that there can be no warning at all. Next slide, please. So we worked really hard on creating a video for parents that I'm going to show you. It's a 4-minute video, and it has a special guest star in there that you may recognize. But really what we wanted to do was to provide information to families about what newborn blood spot screening is, take the mystery of it, show the lab, which is here in Hillsborough, so that people can kind of get an understanding of why this program is so important and why every baby should be screened. So I will let Ellen start the video.
Yeah, let me pull it up here. Just gonna drag it over here. Let me know if there's any sound issues, but I think we should be good to go.
When a new precious life enters this world, healthcare providers do all that they can to provide care and comfort to the baby and new parents. Physical examinations of the baby are performed to look for signs of illness or distress. Blood tests are ordered to look for underlying conditions. The newborn blood spot screen is one of these tests. Performed at 24 hours of life, newborn blood spot screening is an opportunity to identify serious but treatable health conditions very early in life that would otherwise not be detected. Every day, physicians, midwives, nurses, and phlebotomists collect a small amount of blood from the baby's heel for newborn blood spot screening. These samples are then rushed overnight to the state public health laboratory for testing. Time is of the essence. Once the samples arrive in the laboratory, scientists make every minute count. On a typical day, over 300 samples are received and tested for over 45 conditions. Results are available within 24 hours. From 5 spots of blood collected on the newborn screening card, instruments punch a small amount of the blood into plates that will be used for each screening test. Some of the screening tests look at the banding patterns of hemoglobin to test for sickle cell disease. Some of the screening tests measure proteins to look for hypothyroidism, cystic fibrosis, or inborn errors of metabolism. Some of the screening tests look to identify newborns with spinal muscular atrophy or severe combined immune deficiency. All of these conditions have treatments that, when provided to the baby, can be life-saving. Here's a story about Maisie, a baby who had a disorder detected through newborn screening.
I'm Conrad.
I'm Leslie, and we have 3 kids, Theo, Ruby, and this is Maisie. And Maisie, on the 5th day of life, had an abnormal result from her newborn screening that led to a diagnosis of MCAD.
When we got a phone call from our pediatrician, he said that there was an abnormal result. And so immediately we were kind of thinking, well, that's really scary. What could this be?
A newborn screening saved us the trauma of one day walking in and her not waking up, or her having a metabolic crisis, or exhibiting symptoms of MCAD.
Her life would have been very, very different, and had there not been the newborn blood spot screening.
And you said this today, that she's one of one. There's only one Maisie. and I can't imagine our family without her. She's truly a gift from God, and I'm just so thankful that something like a little heel stick has given her such a shot at a healthy life.
When a screening test suggests that the baby is at high risk for one of these conditions, the program follow-up staff contact the baby's primary care provider and medical specialists. Together, these providers work to confirm the results of the newborn screen through additional testing and evaluation. If the presence of disease is confirmed, treatment is started. For the public servants of the Oregon State Laboratory, it's all in a day's work. But for the children whose disorders are caught and treated, the impact of newborn blood spot screening is measured not in days or weeks, but in a lifetime. In Oregon, it is mandated in state statute that all babies have access to newborn screening. Families, providers, policymakers, and advocates make sure that no baby is denied screening.
All right, thank you for taking the time to watch that video with me. I've probably seen it, over 100 times, and I still tear up a little bit at the end, really just because I got to meet Maisie and her family. One of the things her mom said to me, which kind of was reflected a little bit in the video, was, when do I want to find out about this, right? When do I want to find out that my baby has a disorder? Do I want to find out ahead of time when I can put preventative measures into place? Or do I want to find out when it's a crisis or when it's too late? And I just thought that's really powerful to hear from a family who was impacted by newborn blood spot screening and having a positive result and then confirmed disorder. Next slide, please. So how can the WIC nutritionist support the newborn blood spot screening program? Well, you're certainly welcome to review the video with parents or have it available to view in your clinic waiting room. We have a QR code. We have a little bit.ly shortened URL code. That's actually on the back of our pamphlets. So if you don't have any of our newborn blood spot screening pamphlets, they are available to order at no cost from the state lab. And just a really good tool for families to learn more about newborn blood spot screening. So offering them that pamphlet, ideally during pregnancy, and that's kind of one of the areas I'll be focusing on this year, is really working hard to get the information into the hands of parents ahead of time, not when they're in the hospital delivering a baby. That's not a great time to be learning something new, right? So focusing on getting the information into the hands of families prior to having that baby so that they have time to understand and ask questions. Other ways that WIC can help support this program, support families to pick a primary care provider during pregnancy. We need that information. It needs to be written on our specimen collection card. And for some families, it's just nothing that they have thought about during the prenatal period. They're so focused on being, the pregnant person being seen by their midwife or their OB doctor. Sometimes they forget that the baby's also going to need their own provider. And it's very helpful for us that we, after baby's been discharged from the hospital, if we have a positive result, we need to know who to contact. So we need that primary care provider information to be on our card. So just helping support families and understanding that that's a decision that you should try and make ahead of time. And then referring family to educational resources for additional information. We're one of those programs through the Oregon Health Authority that it doesn't get talked about a lot, and we'd really like to change that. We want every family to accept newborn blood spot screening because they understand how important it is and how life-changing it could be for their family. So getting that information out there more broadly through our community partners is really helpful. Next slide, please. Other ways that the WIC staff and nutritionists can support our program is to ask questions. Did your baby receive 2 newborn blood spot screenings? Did you get those results? Was any repeat or additional testing ordered? Was there any follow-up indicated? Sometimes we have families who kind of drop off. So we call them lost to follow-up because maybe they had their first screening done in the hospital, but then they never show up at their primary care provider's office for a second screening. Or we may have a family and they have a positive screen, and for whatever reason, they never follow through with confirmatory testing, which is really scary, to be honest. And we do our best to track down families through their primary care provider. But it is up to the family to have the testing done and to agree to the testing. And sometimes families just kind of they disappear. So the more people surrounding families that can ask them questions just to make sure that all the follow-up that's been indicated has been completed so that we know, oh yes, confirmatory testing and it was negative, okay, great. Or they never got a second screening done. We can screen babies up to 6 months of age. So if you're talking with a family, they didn't have a second screening done, or maybe they didn't have any screening done. Maybe this is an out-of-country adoption and the country that they're living in has very limited newborn blood spot screening or no newborn blood spot screening. Asking those questions and referring families to their primary care provider for follow-up is really, really helpful. And then making sure that families understand what the results were. Did they receive the results from the primary care provider? We still have some clinics who operate under the no news is good news when it comes to results. And I mean, I would never have blood drawn and not expect to see results. So I think we should be setting up that advocacy for families that if their baby has blood drawn, they should expect to hear about results. So I think that's another important way that the WIC program staff can help support our program. Next slide, please. I wanted to touch briefly on our specimen retention policy because questions about this or misunderstandings about this is sometimes where families decide they don't want to do newborn blood spot screening because there's a mistrust of the state, of the government, basically, meaning they don't understand what's going to happen to their baby's blood on the newborn blood spot screening card once screening is completed. So we hold on to all cards for 12 months. We're a secure facility. So the cards are behind 2 locked doors, basically. At 12 months, all specimen collection cards are destroyed securely by our medical waste company. So this means we're not holding on to baby's DNA beyond 1 year. We don't have it, a data file somewhere with every baby's DNA on there. Everything is destroyed at 12 months. We may use unused blood spots internally to validate our equipment, but this means that we're not selling them or giving them away to research companies or pharmaceutical companies. Their baby's not going to be convicted of a crime based on DNA from newborn blood spot screening because we don't have that DNA. We don't store that. The parent or guardian can also request that the specimen cards be returned to them after screening is complete. So if they would like to put the screening card in the baby book beside the shriveled up piece of umbilical cord, they are welcome to do that. Or if they just want to destroy it themselves, they can receive the cards back. And then the screening results themselves are retained for 6 years. But sometimes understanding this information is a tipping point between a family who has declined newborn blood spot screening and a family who will accept newborn blood spot screening. Next slide, please. So additional resources for families. There's a couple of websites. Babiesfirsttest.org is a great website. It has information available on every state, but you can get to Oregon, see what we're screening for. You can read about all the disorders. We also have a section for parents on our newborn blood spot screening website as well that families can review. There's our QR code and the little URL code for the video that I showed you. Next slide, please. And I'm just grateful for the collaboration we can have with our community partners such as WIC. We really have the same goal. We want to support the health of babies in Oregon. So we really do appreciate everything that you do to support that vision for families and to support our program. So the next slide is just to see if there's any questions and then just a couple of options to follow up. You're always welcome to reach out to me if you have specific questions, but we might have a couple minutes for questions, but that's up to Ellen.
Sure, yeah. Does anyone have any questions for Jacqui before she hops off?
All right, well, I don't hear anything. I don't see anything. Oh, how does the consent process happen after delivery? Thank you, Roxanne. That's a really good question. So you're basically opted in to newborn blood spot screening. So, you know, families are told about it, hopefully in the prenatal period, but definitely after delivery, they're informed about it. If they're having a hospital birth, then it's reviewed, you know, prior to collection. Hey, they review the pamphlet with the family, and if the family declines, then they can, right? It is up to them. So we recently changed our rules around what reason could a family give for declining. It used to be it had to be a religious reason, and we've really broadened that to be like it just doesn't match up with the family's belief system, or their, you know, they have an ethical concern about it. So really, whatever the reason is, if a family declines newborn blood spot screening, then there's a declination or refusal form that gets filled out, and it's basically a liability waiver saying, I understand the risks of not doing this screening. So again, we want to make sure families are making an informed decision based on evidence. But if they choose not to do newborn blood spot screening, then that is a choice. But we don't have a consent form that they would sign to do newborn blood spot screening. It's really, we have a form if they decline newborn blood spot screening. What is the percentage of families that decline? So we screen about 98% of families. So it's fairly small. This year we transitioned to a different newborn blood spot card that actually has the refusal form built in to the card, whereas before it was a separate form. So I think we're going to have some better data starting this year and next year, basically, on how many families refuse screening. So what we do is we compare how many babies had specimens collected and vital records. So we look at birth certificates and we look at specimens collected. And of course, there's always a discrepancy there. There's always more babies born compared to specimens collected. So with our new cards, we should be able to capture more data on why the specimen wasn't collected. Maybe baby transferred, or maybe there was a refusal, or maybe baby passed away prior to specimen collection. So we're going to have a little bit more data on that shortly. So, I mean, it's not a huge number who decline, but obviously it's certainly more than what we would want. Is there a low error rate? So we do get false positives and we do get false negatives. I don't have a specific rate available, but what impacts a false positive or a false negative is making sure that it was collected on time, and then the actual process of collection, making sure it's an acceptable specimen with one even layer of blood that the lab can use for screening. So it is a low error rate, yes, but it is dependent on when specimens collection and the quality of the collection. Specimens that are collected early, collected prior to 24 hours of life, have an increased risk of having a false positive or a false negative. Well, I like your question about, will there be a link in twist for newborn blood spot screening? Yes, I say absolutely, but you're right, that is not my my question to answer.
And I think, yeah,
but
Erica just responded with an answer. Yeah, great. Well, thanks so much, Jacqui. If anyone else has any questions, feel free to reach out to Jacqui directly or to me, and we can make sure that we get those questions back to her. I just want to make sure we leave enough time for Vivian as well. So thank you so much, Jacqui, for coming to share more about this program. We really appreciate your time.
Absolutely. Yes. Thank you, guys. And again, just thank you for everything you do for our families here in Oregon. It's so important. Have a great rest of your meeting.
Thank you.
All right. Bye-bye.
Great. So Vivian, I will pass it over to you. You should have sharing privileges. Oh, you're already ready. Great. Thank you.
Thank you. Thank you, Alan, for the invitation, and thank you, everyone, for allowing me to speak with you today. As Alan introduced me earlier today, I work with the Family Child Health, and I support multiple programs, including the Birth Anomaly Surveillance System, as well as the Early Hearing Detection Intervention. And as I'll